Hello, everybody. My name is Cassandra Larson, and I will be discussing intermittent explosive disorder. Intermittent explosive disorder, also known as F63.81 in the DSM, is defined as frequent outbursts that can be attributed to various things: physical violence towards property, animals, or people, or verbal aggressions, tantrums, disagreements, or fights that happen twice a week on an average for 3 months. The second attribute is during a 12-month period. 3. Behavior outbursts that result in property damage, physical assault against people or animals, and the diagnostic features include impulsive or anger based aggressive outbursts that typically last around 30 minutes in response to a minor action. There are two criterias that fall under criterion A, which the first one includes verbal aggression, temper tantrums, tirades, verbal arguments, or fighting, resulting in physical aggression toward property, animals, or others, occurring twice weekly for a period of 3 months. Criteria A1 defines frequent outbursts. The other criteria involves 3 behavior outbursts that do result in physical injury against others within a 12-month period. Criterion A2 defines infrequent outbursts, for example, 3 outbursts in a 1 year or 12-month period. And criterion B, there is a glaring disparity between the level of aggression displayed during the frequent outbursts caused by any action. Criteria C is a recurrent aggressive outburst, however, there is no precalculated motive or intention. And for criteria D, there are frequent violent outbursts that have a negative impact on interpersonal or professional performance, which produce a significant distress in the person or may have financial or legal consequences. Criteria E requires that the individual is at least 6 years old. Criteria F is the last criterion that provides information based on the reoccurring aggressive outbursts and how they are not better explained by other mental disorders. For the course and prevalence of this disorder is a frequent problematic outburst of impulsive aggressive conduct that can seriously affect a person's relationships and quality of life. This disorder often starts during late childhood or adolescence, and it's quite rare for the first instance of these behaviors to occur after the age of 40. Intermittent explosive disorder appears to follow a chronic persistence course of a period of time. For the prognosis, environmental factors such as having a history of physical and emotional trauma during the first 20 years of life are at risk, and also determining if there has been a long-term separation from family members or one's home. Genetic and physiological factors can also contribute to the diagnosis of IED. And the onset of IED usually develops in late childhood or adolescence. This diagnosis can be made alongside ADHD, conduct disorder, oppositional defiant disorder, or even autism. For cultural considerations, healthcare professionals must be aware of these cultural factors when evaluating, diagnosing, and treating patients with IED alongside other disorders. Culturally sensitive methods guarantee that interventions respect the differences in cultural backgrounds and are able to meet the specific requirements of people who are experiencing symptoms of IED in different cultural situations. IED can be displayed throughout individuals differently, and it is crucial to consider all factors in an individual. There is also some association with suicidal thoughts or behaviors that was explained in a study in the DSM that 1,460 volunteers found that individuals who are diagnosed with IED alongside PTSD have a rate of 41% lifetime suicide attempt. For the etiology of the intermittent explosive disorder, the DSM has included the disorder of impulse aggression since the first edition of the DSM in 1952. However, the name intermittent explosive disorder did not exist in the manual until the third edition was published in 1980. Originally, the disorder was classified as passive aggressive personality aggressive type in the DSM 1. IED is estimated to be between 5.4% and 6.9% within the general population, and it is generally more common in men than women. Current theories suggest that there is yet to exist a comprehensive review of genetic and environmental influences on impulsivity. For the assessment of this disorder, various instruments that are used to assess the disorder are questionnaires and interviews. The Intermittent Explosive Disorder Interview modifies IED-M is a semi-structured clinical interview, and another questionnaire known as the Bus-Perry Aggression Questionnaire that contains a 30-question self-reporting questions based on traits containing anger, hostility, or any level of aggression. Differential diagnoses. Being able to differentiate intermittent explosive disorder from other disorders, such as disruptive mood disorder, is crucial, and you are able to differentiate based on the symptoms and the particular age of onset. DMDD, disruptive mood disorder, is seen before age 10, where IED is seen later on. Also, individuals with IED who display levels of irritability and anger is shown for a smaller period of time compared to those who are diagnosed with DMDD. Antisocial personality disorder or borderline personality disorder differs from IED because those who are diagnosed with antisocial personality disorder or borderline personality disorder display recurring impulsive outbursts, but not at the same level of impulsive aggressive behaviors to those that have IED. Delirium is another differential diagnosis. However, for those who are experiencing delirium and major neurocognitive disorder, it is crucial to not diagnose an individual with IED. And attention deficit hyperactivity disorder, also known as ADHD, may display impulsive aggressive outbursts, which is typical for individuals with ADHD. However, IED differentiates based on the level of aggression. Substance intoxication or substance withdrawal is another differential diagnosis. However, being involved with substances may increase aggressive behaviors. However, those who are involved with substance intoxication or substance withdrawal and only have outbursts when intoxicated or having withdrawal should not be diagnosed with IED. The treatment for this disorder is cognitive behavioral treatment, CBT, or family treatment, changes in one lifestyle, avoid substance use, and increase relaxation methods and self inoculation training, multi component treatments, as mentioned before, inclusion of both cognitive and behavioral practices. Medications are also used, including mood stabilizers, antidepressants, particularly selective serotonin reuptake inhibitors. For a case brief, Mark, a 35-year-old businessman, is deeply involved in preparing a presentation while seated at his desk in a busy workplace. Mark's focus is broken as his phone rings. He has been anticipating a very important work call, only to find out the caller is a telemarketer. He feels a rush of frustration come over him instantly. He originally makes an effort to deny the offer, but something is triggered in by him. As the salesperson continues to be persistent, Mark's voice becomes extremely stern and he becomes angry and starts to yell into the phone, saying harsh remarks and verbally abusing the telemarketer by calling them unpleasant names and making threats. His coworkers nearby exchange nervous looks as his outburst gets progressively worse. Mark keeps on ranting despite his coworkers' attempts to calm him down, and eventually he calms down and hangs up, feeling distressed and panting heavily. Mark feels a mixture of shame and regret for his outburst in the office. However, for Mark, this is not the first time that an outburst has occurred. He has seen similar experiences throughout his life where somewhat smaller incidents turn into violent outbursts. Following these outbursts of extreme rage that are out of proportion to the situations that set Mark off, he feels ashamed. Reviewing this case, we can see how Mark exhibits the symptoms of intermittent explosive disorder, IED, which is a disorder that is marked by frequent, impulsive, violent outbursts. His outbursts are often triggered by small, insignificant events following some levels of embarrassment. Some may think that Mark should be diagnosed with borderline personality disorder. However, given his aggressive and violent acts and strong mood swings, and his main pattern main pattern of explosive outbursts allows us to diagnose Mark with IED. To differentiate IED from other disorders, that may exhibit similar symptoms, understanding differential diagnoses is essential for people like Mark to receive the proper diagnoses and treatment that will help him further manage his outbursts. And here are my references. Thank you.